How are you, Dr. Balbali?
Good. How are you?
I'm doing good.
Happy Mother's Day to everyone.
I'm sorry?
Happy Mother's Day to everyone.
Happy, that's true.
Yeah.
We couldn't do anything without them.
Yep.
It's kind of muggy, gloomy day today, but I'm sure Mother's Day is going to be very cheery.
I'm not sure how many moms are going to join us today, but we have quite a few here.
Right.
Quite a few who've joined us already, so that's good.
So is the audience a mixed audience? Is it all physicians or?
Yes, no, we have physicians and non-physicians as well. So we're trying to cater to the needs of both.
All right. So we have to, adjust the talk accordingly, I guess.
Yes.
Yeah, I think Meenakshi was saying it make it more for non-physicians because otherwise it'll be difficult for them to understand,
Sure.
Especially the medical aspect of things.
Are we able to see who has joined us?
Yes, you can see in the participants, I think we have 16 so far, so that's a good number to start with. So I think we can just get started and
Sure.
Thank you everyone for joining us for another session of the webinar series from the MVAPI Living Better series. And this month is as a part of Asthma and Allergy Awareness Month. We have two experts here with us to discuss topics of these issues regarding allergic rhinitis and asthma. And I think we have a good number of participants here, so we can get started, and we look forward to your questions at the end of the speaker's talk. So first we have Dr. Atul Balwali to discuss about allergic rhinitis. He is a partner in Southwest Ohio ENT Associates and has been practicing in the Dayton area for almost 25 years. He is also a clinical assistant professor at Wright State University School of Medicine, and he has trained at State University of New York in Brooklyn, and he did his medical school at the University of Cincinnati. And it's really good to have Dr. Balwali here, who can share his expertise about a very common topic which most people will encounter, that is allergic rhinitis. And we're looking forward to having questions from the audience about this topic. Take it away, Dr. Balwali. Thank you.
Yeah, thank you. Thank you for inviting me, and thank you for everyone being here. I first want to wish everyone a happy Mother's Day. I do want to specifically single out two mothers that I know, my wife Anjali and my mother Hemlata, who's, I think they're logged on. They're in my opinion, the two best mothers in the world. So let's start off about talking about allergic rhinitis. It's a very timely topic, especially here in the spring. As I was just mentioned, I'm an ear, nose, and throat doctor. So we have the ears, nose, and throat. So we're not going to talk about the giraffe or the rabbit today. We're going to talk about the elephant in the room, mainly the nose. So allergic rhinitis is really also just allergies. It's also known as hay fever. It's a chronic inflammatory disease of the upper airway. So I'm going to be pretty much talking about the nose and sinuses, and it's caused by an immune reaction. And I'm glad Dr. Patel is here today because he's going to be talking about asthma, and there's a commonality between asthma and allergies, but it's an immune reaction to things that are otherwise not harmful in themselves, like pollen. It's mediated by an antibody called IgE, and this is a very important concept. And interestingly, IgE antibodies are only found in mammals, and it's the lowest of all the classes of antibodies. It accounts for only 0.05% of all the antibodies in the immune system. So what happens when you are exposed to an allergen? The first time you're exposed, there's really no reaction because there's no IgE antibody. So the IgE antibody starts developing, the immune cells become plasma cells that produce more IgE antibody. The antibody then binds to the allergen and then binds to a cell called a mast cell. And then the mast cell releases granules, mainly histamine. So this is an important concept because a lot of the treatment for allergies are designed to block histamine release. And then that leads to all the allergy symptoms. So this is kind of a busy slide, But the most important thing here, you'll see from the early phase to the late phase reactions, histamines involved in all of these. Also, leukotrienes can be involved in the runny nose and also the blockage of the nose. And there are certain medicines that block leukotriene and inhibit leukotrienes. So you start off with sneezing, itching, the runny nose, and then the late phase reaction is the nasal blockage that people suffer with allergies. So what's important about the IgE antibody? Is it there just to produce allergies for people? Not really. The IgE antibody is designed to reduce the parasite load. And so when you have a parasite either on your skin, it causes itching and you scratch the parasite off. If it gets into your nose or into your airway, you sneeze and cough and you blow it out. Or if it gets into the intestinal tract, you have either colic or diarrhea, and then you remove the parasite that way. So I always been asked, or I'm asked by people, why are allergies more and more common? And it is true. I mean, if you look at the last 100 to 120 years, in the last century, allergies have actually really increased in prevalence. 25% of the world's population in the industrialized world now has allergies. But if you go back or go into the developing world, only 4% of the population has allergies. And so people have tried to figure out why this is the case. In the past 100 to 120 years, I don't think genetics really has changed very much. So genetics probably doesn't have a cause for increasing allergies in the world over the past 100 to 120 years. There's a environmental hypothesis, this hygiene hypothesis, which is also actually a hypothesis of why we have more autoimmune conditions now. And it's thought that with improved hygiene, there's less infections. And with less infections, you don't stimulate the immune system as much. And if you don't have immune system stimulation, you may end up having more of these IgE antibodies, and that may lead to more allergies. So that's a possibility. Pollution, nutrition, poverty. Pollution may be more in the industrialized world, but nutrition and poverty are certainly more, I think, in the developing world, in the third world. So those patients don't have nearly as many allergies. So I don't know if you can really point to nutrition or poverty as the cause of increase in allergies. But the interesting thing is this worm infestation. If you go back to 100 to 120 years ago, pretty much everyone in the world had worms in their intestinal tract. Now, only 25% of the world have worms in their intestinal tract. And worms are actually a parasite, and they release chemicals that inhibit the immune system, and that's how they can live in the GI tract. And so by doing that, it decreases IgE production. So by getting rid of worms, I think that's actually led to more immune problems, including allergies. So epidemiologically, there's 60 million children and adults in the United States who have allergies. And just like other autoimmune conditions, such as Crohn's disease or ulcerative colitis, it peaks in the second and third decades of life. So all these immunologic or autoimmune processes, I think, have a tie that binds them together. If you look at physicians' diagnosis, at least in the United States, 15% of patients have been diagnosed at least with having allergies or allergic rhinitis. So what's important about allergies? Well, it affects the nose. And what's the nasal function? It's mainly to warm the air that we breathe. It humidifies the air that we breathe, so when it gets to the lungs, it's not too dry. And it removes particulate matter and impurities before they reach the lower airway or the lung. So allergies or allergic rhinitis is really found in a lot of patients with asthma. So 80% of asthma patients actually have allergies. So that's that immune commonality between asthma and allergic rhinitis. If you have allergic rhinitis, it doesn't always mean you're going to get allergies. 40% of patients who just have allergies will eventually end up with asthma. And then depending on different studies, allergies or allergic rhinitis is found in 25 to 75% of patients who have chronic sinus problems. So in our practice, when we take care of sinus problems, we also take care of the allergies because a lot of patients have allergies as the underlying cause of sinusitis. And if you don't take care of the allergies, they're likely to continue to have sinus problems. So if you can adequately treat the allergies or allergic rhinitis, you're going to decrease the frequency and severity of sinus problems and asthma. So we just talked about asthma and sinusitis, but allergies can also lead to upper respiratory infections like colds, ear infections or otitis media. And it does that by affecting a tube called the eustachian tube that goes from the ear to the back of the nose. And eustachian tube issues will lead to ear problems. Conjunctivitis, which inflammation of the lining of the eye, or nasal polyps, can also be related to allergies. And then there's secondary, and just as important, is the decrease in quality of life. So when you have allergies, you don't feel good. And if you don't feel good, you're not nearly as productive. Also sleeping, if you have a blocked nose or congestion, you're not going to be able to sleep well, which means you're going to be tired throughout the day. And again, it's going to affect your productivity. And then there's also learning and attention impairment or deficits because of nasal issues, including allergies. And then finally, mouth breathing. So if your nose is blocked, you're going to end up breathing through your mouth. And especially in kids, if you're a mouth breather, you'll end up having dental problems. You'll have a high arched palate, your teeth come in crowded. Eventually, you end up needing braces or some sort of dental appliances. And so whenever we see a patient with really any problem, the first thing we always do, of course, is get the history. So let's just look at the symptoms of allergies. And most people know because, you know, especially living in this area, allergies are ubiquitous. And so blocked nose. 76% of patients with allergies will complain of blocked nose, followed by sinus pressure. And then just the sneezing, the runny nose, the itchy eyes. 64% of patients have all of these symptoms. And then postnasal drainage, where actually you have mucus draining from your nose to your throat, is very common, along with headaches. And then the timing, when we get the history, you try to find out when this happens. So if it's in spring, it's usually tree pollen. So right now the trees are pollinating, and that's what causes a lot of the allergies this time of the year. When we get to summer, it's more grass pollen. And then ragweed or weed pollen is much more common in fall. Patients who have symptoms all year round can have just the outdoor allergens, but also usually have some indoor allergies, because in winter, we don't really have anything pollinating outside. It's more indoor stuff that could be pets or dust mites or molds, feathers, if you have feathers in your pillows, and even cockroach you can be exposed to, especially if you live in apartment complexes or in certain homes. And then the duration and frequency. So we ask how long have the symptoms been present and how often your symptoms occur. So along with the history, you look for environmental triggers. So pets can be an environmental trigger. Different cats, different dogs. You know, there are patients who have pets at home, and when they're exposed to them year round, they're using their allergens or you're using their antibodies, so they don't have nearly as many symptoms. But when they leave the area, especially school children, they go off to college, they come back home, and all of a sudden their pet, their cat or their dog really starts affecting them. And that's because those antibodies have built up over that time that they've been gone. When they come home, all of a sudden they have symptoms. Exposures at school, exposures at work, and also lead to environmental triggers that cause allergies. And then we ask about the family history, because if one parent has significant allergies, there's a 50% chance that their child will have allergies. But if both parents do, it's about an 80% chance of having allergies. And then second, after the history, we do the exam. So when you look in someone's nose and they have allergies, their mucosa or lining of their nose is really pale, it's congested. The turbinates, which are structures that come from the side of the nose, they're little balls that you can see inside your nose, become really swollen and purple. You can sometimes see nasal polyps. That's usually a little further inside the nose, but if they're really large, you can actually just see them looking inside the nose, just through the nostrils. And then a nasal crease, or also called an allergic crease, is where if you have allergies, you're always kind of pushing up on your nose like this and sniffling. And if you do that repeatedly over time, you'll form a small crease over the nose. I have a picture of that. And then swollen and puffy eyes are very common. And these allergic shiners is it's kind of purplish, darker look to your eyes that occur from allergies. It's just increased blood flow in that area from inflammation, and the veins cause more of a purplish look of your eyes. So this is a picture of the nose. This right here, I don't know if you see this arrow, but this is the turbinate. That turbinate is really swollen, and the mucosa or lining of the nose is congested. You can't really see inside the nose very well. And then these are also turbinates. These purplish structures are turbinates. And you can tell just by looking at this person, they're going to have a hard time breathing through their nose because they're so congested and so swollen. And then this is a CAT scan of the nose in a person who It doesn't really have any sinus problems. These are sinuses on the sides. They look pretty clear, black being air. But inside the nose, this nasal cavity, it's called central compartment congestion. The central part of the nose is all swollen and congested. And if black is air, you can tell they'll have a hard time breathing through the nose because there's not much black in the nose down here. It's all gray with tissue and swelling from allergies. And this is a similar type of picture inside the nose. This is using a telescope looking further in, and it definitely looks congested and swollen inside the nose. And this is a polyp. This is, again, using a telescope. This is not something that I would be able to see just opening someone's nostril, but looking further in, you can see this big polyp, and that can also be caused by allergies. And then finally, this is the allergic crease. So there's a line right here. So this little boy was constantly pushing up on the nose and eventually caused a little crease over here called an allergic or nasal crease, and that can be a sign of allergies. And then finally, this puffy eyes and allergic shiners. You can see it's kind of dark underneath the eyes, almost like he got hit in the eyes on both sides, but that purplish, kind of pale, congested look is from allergies and these allergic shiners. So how do you truly diagnose allergies? Well, we talked about the symptoms. You have to have at least 2 or more of these symptoms for greater than 1 hour per day. But really, to diagnose allergies, you have to test for these IgE antibodies. And you can do the testing 2 different ways. You can do skin testing, and that's what we prefer to do in the office, skin test. And we do this intradermal testing, which is a little skin prick, and we put it underneath the skin and put the allergen underneath the skin and see if there's a reaction. Or especially in kids who can't tolerate these little needle stick, you can do a skin prick. But if they can't tolerate either of those, you can actually do a blood test called a RAS test. And so that looks for the IgE antibody in the bloodstream itself. So what do we test for? So you test for seasonal stuff. And this all depends on the area of the country you're living in. So we're not going to test for the most common allergens in the west part of the country or in Arizona or south. We test for the Midwest allergies. So we test for different trees, we test for different grasses, we test for different weeds. And those are the seasonal allergens. But then there are people who respond or react to, not respond, but react to year-round or perennial allergens. So we test for dust mites, we test for pets, we test for molds, feathers, cockroach. I always tell people when they test positive for cockroach, it doesn't mean that they have cockroaches in their house, but they've been exposed to the cockroach allergen. And that can be in any public space. It could be in their schools that they were in, or it could be in grocery stores where they worked, or their workplace. So it doesn't mean that they don't take care of their house. It just means that they've been exposed to cockroach allergen in the past. And then the treatment starts off with trying to avoid the allergies as best as you can. If you have seasonal stuff in the spring, summer, and fall, it's very difficult to not go outside. But when you are indoors, keep your windows closed. At night, when it's a nice evening, and you're sleeping, don't keep the windows open. So keep things closed as best as possible. Try and avoid going out as much as you can. But again, it depends on how allergic you are. And then saline sprays, like a neti pot, can be used. It helps wash out the allergen that's in the nasal cavity. And people do this once, sometimes even twice a day, and that kind of cleanses the nose and then gets rid of a lot of the allergens that are in the nose. But from a true treatment standpoint, the first thing we try is these nasal steroid sprays. A lot of these now, or at least the first 2, have gone over the counter. They used to be prescriptions, but they have gone over the counter. So you can get Flonase, or you can get Nasacort. Nasonex, I think, will be over the counter soon. It might be over the counter already, but again, it's a prescription. There's a few other prescription medicines also. A lot of the insurance companies these days don't cover it because Flonase and Nasacort is over the counter. But it's once a day, and you can use that, and you have to use it on a regular basis. You have to build up a level in your nose. It's a low-dose steroid that reduces inflammation and congestion in the nose. So that's the first-line treatment that we try. Patients who continue to have symptoms despite that, then you try the antihistamine. Benadryl is an antihistamine that can be used. The only problem with it, though, is it causes sedation. In fact, if you look at some of the cold preparations, they have Benadryl in it that helps you sleep at night when you really have a cold. But Benadryl during the day can affect how well you can work and your productivity. It makes you pretty sleepy. So because of that, non-sedating antihistamines have come into vogue, and they've been around now for a while. And again, all of these have gone over the counter. Again, used to be prescription, but over the counter. So Claritin or Allegra or Zyrtec or Zizal, which are daily prescriptions once a day, can be used in conjunction with those nasal steroid sprays. But we first try the steroid sprays first, and then the antihistamines second. And then for patients who also continue to have symptoms despite that, you can use a topical or a nasal spray antihistamine called azilastine or Astelin. That's actually a prescription medicine. And then for eye drops, there's an antihistamine eye drop, Patidate, and that's for the eye itching and redness. And then finally, for a lot of the congestion, we can use a decongestant like Sudafed. So Sudafed, you can get over the counter, but you actually have to sign for it because people do make illicit drugs out of Sudafed. And it can be attached to the antihistamine, like you can get Claritin D or Allegra D, Zyrtec D, Zizal D, that's Sudafed attached to the antihistamine. But again, you have to sign for those. It's not a prescription, but you have to sign for it. And then they do keep a tab on how much you buy, just so that someone who buys a lot of it may be actually using it for another reason, not just for their nasal problems. And then this leukotriene inhibitors, one of the slides I had early on, leukotrienes was one of the causes of the kind of late phase reaction. So this is also used for asthma, and Singulair can be used. And we usually use that as a third line treatment. So the nasal steroid sprays, antihistamines, and then we follow it up with Singulair. And then some of these other things, the topical and eye drops can be used also with that. So if you just have grass allergies, there's actually a sublingual or something you put underneath the tongue pill called Grassex. They're used for grass allergies. You have to start it about 2 months before grass season, and that's a summertime allergen. So summertime allergens usually start in June. So you'd have to start this about early April and then continue it through grass pollen season, which ends around mid-August. And then if you have just dust mite allergies, you can get a pill, a sublingual pill called Odactra. Also for that, again, that's a daily thing you have to use. When you start using these, initially you end up having some, you can have tingling in your mouth, you can have a little bit of swelling, you can use some antihistamines with it, but after using them a couple of weeks, that starts going away. And this actually does help, but you have to use it each of these seasons, although dust mites are year round, so you have to use this year round. And then allergy shots. So, allergy shots are for those people who've tried medicines and you continue to have symptoms, and then their allergy testing have shown severe reactions to multiple allergens. So we offer this good thing called immunotherapy or allergy shots, and they can be sublingual drops too. You can use shots or drops now. But the design of that is actually to change the immunology or immunity to the allergens. So when you're exposed to the allergen, rather than having an IgE antibody attack it and start this cascade that leads to allergies, by using this immunotherapy, you can change it so a different antibody called IgG attacks it, takes it out of the system before IgE can even attack it. And that way, you won't end up getting allergy symptoms. So it's designed to prevent allergic symptoms, it modifies the disease, and eventually it may even give long-term disease remission. So if you've gone through allergy shots, it can help you long-term, not just when you're on them, but years afterwards. And again, as I mentioned, it's indicated for patients who have poor symptom control with the standard medicines. So how do we give immunotherapy? So allergy shots, and you have to come in on a weekly basis. And so if you can do that, that's great, but there's a value to your time. So you'd have to drive into the office, you have to get the allergy shot, you have to sit and wait about 20 minutes to make sure you don't have a reaction, and then you drive home. So each week it takes maybe an hour, and depending where that office is, hour to an hour and a half out of your day. So not everyone can have a schedule where they can get allergy shots. They may not be able to get off of work, and especially kids in school. And when they go to college, allergy shots might not be something that they just works in their schedule. So sublingual drops is something we offer now also. So it's a similar concept. You're given the same stuff you're allergic to, but rather than getting it as a shot, you get it as a drop. You put it underneath your tongue. You do it on a daily basis. And you can actually get to what's called maintenance, which is a maximum dose of the shot, much faster with sublingual drops. The only problem with sublingual drops is, unfortunately, most insurances don't cover it. So it becomes an expensive proposition. And so you have to have enough disposable income to go through the drops. But for people who can't make it into the office, kids who are students, it's actually a great option. regardless with allergy shots or allergy drops, you have to be on it for at least 3 to 5 years to change your immunity or immunology to the allergens that you reacted to. And then surgery. Now, surgery doesn't change allergies. I mean, that's not the design of this. But let's say you've gone through medicines and you've been through allergy shots or allergy drops, and you're still having symptoms where you can't breathe through the nose, your turbinates are still really congested, or you have a deviated septum, you have polyps in your nose, then surgery can correct the deviated septum so you breathe better. And more importantly, you can reduce the size of those turbinates to establish an airway. And if you do have polyps, you can actually remove the polyps. That improves your nasal airway, improves your breathing, and then you can at least tolerate the allergies better. Okay, and that's pretty much my talk for allergic rhinitis. Again, I want to wish everyone a happy Mother's Day. So if anybody has questions, I'll be happy to entertain those after Dr. Patel's talk.
Thank you so much, Dr. Balwani. That was indeed informative. I will leave the floor to Dr. Meenakshi Patel now.
Hi, it is my pleasure to introduce Dr. Rajesh Patel. He has been in private practice in Dayton since 1989. He is the founding member for the Pulmonary Critical Care and Sleep Medicine practice in Dayton, Ohio, and most of you are familiar with that. He is board certified in internal medicine, pulmonary medicine, and sleep medicine, and he's a fellow of the American College of Chest Physicians. He is an assistant clinical professor at Wright State University, and he will be presenting the topic of asthma. Thank you, Dr. Balwani, for such an excellent talk on allergic rhinitis, and the asthma talk will now complement that talk for us. So take it away, Dr. Patel.
Good afternoon.
So Rajesh, you need to go to slide presentation, so you can.
This is the way, unfortunately, it's coming up. Sorry.
Okay.
So good afternoon. Bear with some technical inadequacies on my part. Thank you for inviting me for this talk in asthma. I also would like to wish every mother a happy Mother's Day. As the saying goes, there's only one beautiful child in this world and every mother has it. Likewise, there's only one beautiful mother and every child has it. So happy Mother's Day. As I was looking at the participants on this phone call or in the Zoom meeting, I do recognize a few of them, but there are a lot I don't. And I'm sure there is a mixture of doctors and non-MDs. So I will try and keep my talk such as interesting to all of them. So before I start off with asthma, I wanted to just give a brief concept of what the lungs are. The lungs are like the tree outside. You have a central trunk like the trachea, and then you have branches which branch within the breathing tubes or within the lungs in the chest cavity, and they go on for 17 generations. And then just like in the tree, they end in the leaves. In the lungs, they end in small balloons called alveoli. So asthma is a disease of the breathing tubes. It is a conducting system that takes in the air which you breathe in and transmits it to the balloons in the lungs. And so asthma affects this conducting pathway or the breathing tubes. And they affect the mid-size and the small-size breathing tubes in the lungs. Hence, asthma is a chronic long-term condition that affects the airways in the lungs. The airways are tubes, as I was mentioning, that carry air in and out of your lungs. If you have asthma, the airways become inflamed and narrowed at times. Can you all see the slides this way?
Yeah.
All right. The burden of asthma in the US, approximately 24.7 million people experience asthma. Each day there are 30,700 people experiencing an asthma attack, 4,900 emergency room visits, 500 hospital inpatient stays, and 9 deaths. The good news is that from 1999 to 2016, there is a 41% drop in the mortality of asthma. So these 9 deaths which we are seeing were much higher in the late 1990s to early 2000, but has dropped quite a bit now. Asthma affects people of all ages and often starts during childhood. Symptoms usually manifest by way of wheezing, cough, or feeling of chest tightness. Symptoms can range from mild to severe and can happen every day or only occasionally. Certain things can set off or worsen asthma symptoms such as cold air. These are called asthma triggers. As Dr. Balwani mentioned, there are triggers in the environment that would probably cause release of certain cellular chemicals within the body, which then cause the symptoms of asthma by way of cough or wheezing, chest tightness, or shortness of breath. Wheezing, which is often associated with asthma, is a whistling sound that is produced when the air flows in and out of small airways, which are narrowed at a high flow rate. Normally, the body's immune system helps to fight infection. However, in some people, this immune system responds inadvertently and vigorously to a substance in the environment called an allergen, triggering asthma symptoms. The pathophysiology of asthma, it's a heterogeneous syndrome which encompasses different clinical phenotype. What is a phenotype? A phenotype is the observable characteristic of the disease. That means when somebody has a cough, wheezing, shortness of breath, or chest pain, that is the phenotype of that particular disease. Most of asthma phenotypes are associated with cellular inflammation in the airway, sputum, and blood. An endotype. What is an endotype? These are newer terminologies that recently have been coined. An endotype is an inflammatory or an immunologic mechanism driving the asthma phenotype. So a phenotype is something that is manifested, that is something that is felt and seen, whereas endotype is the intrinsic mechanism that drives the phenotype. Each phenotype in asthma may have one or more endotype driving their clinical presentation. So in short, basically asthma has a lot of allergic components to it, and there are several mechanisms that can cause these allergies, releasing various types of cells, which in turn then manifest by way of symptoms. There are two main types of endotypes, type 2 and non-type 2 endotype. Type 2 inflammation may account for about 50 to 70% of asthmatics. These are mainly driven by cytokines, interleukin 4, interleukin 5, and 13. They also have an elevated IgE, as Dr. Balwani pointed out, and they may have variable airway tissue and blood eosinophilia. Eosinophils is an important cell in asthma. It is triggered by allergens, and when it is triggered and it disintegrates, it releases various chemicals which cause the narrowing of the breathing tubes. The narrowing of the breathing tubes usually occurs because there's muscle that wraps around the breathing tubes, and there are two types of muscles in the body, the skeletal and the smooth muscles. This is the smooth muscle that wraps around the breathing tubes, and then they go into a spasm, and that narrows the breathing tubes, and that's what causes symptoms of shortness of breath, cough, and wheezing. Non-type 2 inflammation accounts for 30 to 50% of asthmatics. Cytokines and inflammatory cells are not well characterized in this inflammation. There is no eosinophilia noted. However, if you were to collect the sputum and look at it under the microscope, you would see a significant number of what we call polymorphonucleosides. Typically, they do not have IgE elevation. So this is a simplistic diagram where the top of the diagram shows a normal breathing tube. As you can see, the white circular part of the breathing tube is the muscle. Then you have the cross section of the muscle and then the mucosa. In the lower end, you can see that the mucosa has got significant secretions. The muscle is contracting and the mass of the muscle has increased quite a bit. And as asthma is frequently triggered in a given person, this causes hypertrophy or enlargement of the muscles, which is what causes the symptoms. In asthma, it is counterintuitive. In asthma, one would think that it is difficult to breathe in, but it is the breathing out that is more difficult, because breathing in is an active process where the muscles participate and suck the air in. It is breathing out, which is a passive process, which is dependent on the elasticity of the inherent elasticity of the alveoli or the balloons of the lung, which push the air out. But when the airway is narrow, it becomes difficult for the balloons to push the air out before the next breath comes in. And so the lungs become bigger than the chest cavity it was made to fit in. Consequently, the amount of air subsequently will become less and less, and they become more and more short of breath. There are various risk factors that trigger asthma. Again, just to belabor the point Dr. Balwani made, there is a lot of environmental allergies, cigarette smoke, different microbials in the environment, workplace such as fumes, wood dust, air pollution. Not only will they cause allergic rhinitis, which may be the precursor of asthma or may occur concomitantly, but these are the things that would sometimes trigger asthma. Asthma does have a familial history. It runs in families, and so there must be a genetic component. We just mentioned allergies. Obesity is an independent risk factor for asthma. Respiratory tract infections, especially in the flu season, we see an increase in the number of asthmatic attacks. Race, it is initially noted that in the younger population, it is the white Caucasians that have an increased incidence of asthma. However, in the adult population, it is mainly the African American population that has increased asthmatic frequency. During the childhood, the male to female ratio is 2:1. In the adults, however, it is more common in the females. The most common symptom in asthma is cough. And sometimes besides cough, there is no other symptom. And sometimes it is triggered with exercise, and as the breathing gets a little bit faster and the person is not breathing entirely through the nose, so the air is not warmed and moistened, like Dr. Balwani pointed out. The air goes through the mouth, and sometimes this dry air and the change in temperature of the air at the level of the mucosa of the breathing tubes causes a flux of temperature there, which then causes the muscles to go into a spasm, which may cause coughing. And this is frequently seen in children, adolescents who start to participate in sports and other physical activity. And this is called adult onset. This is called exercise-induced asthma. And this is easily treated with just a short-acting albuterol or a Ventolin inhaler. Chest tightness is another common symptom. Shortness of breath and wheezing. These are the four most common symptoms that are seen in asthma. Asthma attacks or exacerbations are episodes that occur when symptoms get much worse and require a change in typical treatment. They can come on gradually or suddenly and may be life-threatening. People with severe asthma tend to have asthma attacks more frequently. Usually, asthma is more commonly seen in adolescent and young children. When they are frequently challenged with allergens, they continue to have asthma, and it becomes such that the child or the adolescent feels that this is the normal way of life and sometimes ignores the symptoms, ignores treatment until it becomes quite severe. This also sometimes happens in adults, and this may eventually lead to what we call emphysema or emphysematization of the lung, which is where the balloons, because they have to continuously work against a higher resistance of the airway, they lose their elasticity and they become permanently enlarged. It's like a rubber band that has been pulled once too many times. It loses its intrinsic elasticity. So when you breathe in, the balloons inflate and are not able to completely deflate due to the loss of the intrinsic elasticity. And so the lungs then become bigger than the chest cavity they were made to fit in, resulting in decreased amount of air intake, which in turn then causes shortness of breath. So how do you diagnose asthma? What are the diagnostic tests? So these are the frequently done diagnostic tests: pulmonary function test, bronchoprovocation test, peak expiratory flow rate. Recently, fractional exhaled nitric oxide test has been developed, an allergy test, skin and blood test, as Dr. Balwani pointed out. What are pulmonary function tests? Pulmonary function tests are simple tests during which the patient breathes in and out multiple times in a computerized machine. They usually measure flow rates, airflow resistance, the volume, lung volume, and the ability of the lung to transfer oxygen from the lungs to the bloodstream. More sophisticated tests would also lead sometimes to know whether there is upper airway obstruction by way of vocal cord paralysis or tumors that are above or below the vocal cords. It could give us a clue. And those are called flow volume loops. Sometimes we are not quite sure whether the symptoms that the patient is presenting is asthma or it could be from some other etiology. Pulmonary function tests may not be able to differentiate sometimes very accurately whether the patient does have asthma or not. So in those cases, we do what we call a bronchoprovocation test or a methacholine challenge test. This is a test where we try to induce bronchospasm in a patient. So they are given inhaled provocative agents, and the pulmonary or spirometry, which is one part of the pulmonary function test, is done in a routine sequential manner. And we try to figure out whether they have wheezing or they have decreased flow rates, more than 10%, then we would say that the patient does have asthma. Oftentimes, patient with asthma has been given what we call a peak flow rate, which is a simple device or which the patient keeps with themselves, especially if they're having frequent attacks of asthma. A peak flow rate is a device where you take in a deep breath and blow as best as you can through a certain instrument, and that will give you the rate of flow of the air which you've blown into that instrument. Normally, it is 400 to 700 liters per minute, and you record your best effort when you are free of an asthma attack. If and when you have symptoms and you blow into the peak flow meter, and if your flow rate drops to below 50%, that is a severe attack of asthma, and you should seek the emergency room. Between 50% and your best effort, there are various things that you can do to prevent worsening of your asthma. Recently, fractional exhaled nitric oxide has come into vogue. Exhaled nitric oxide is a product of inflammation, and there are now devices that can measure the nitric oxide in the breath. This is useful in knowing whether there is ongoing inflammation despite absence of any symptoms. It has been shown that even after the symptoms have dissipated following an exacerbation of asthma, the fraction exhaled nitric oxide continues to be high for several days to maybe a couple of weeks after the cessation of asthma attack. And this has led to some thinking where we should be prolonging the course of treatment with steroids in those patients. When the fractional exhaled nitric oxide is greater than 33 parts per breath, then that is a predictive response to inhaled corticosteroids. Less than 22, you could start to wean the steroids off. I think Dr. Balwani has eloquently described skin allergy testing, so I would skip this slide. Treatment plan and goals. So the biggest, the most effective way of treating asthma is to prevent it. Knowing what is causing asthma, the allergens, and whether there are certain seasons that provokes asthma, whether it's the pets, the work environment. So those are things which over a period of time, the patient will come to know and needs to prevent or isolate himself from those conditions so that asthma attacks are not frequent. Treatment is dependent on age and asthma severity. We continue to adjust the treatment of asthma until appropriate response to treatment is obtained and symptoms are controlled. Asthma treatment can be classified into short-term relief medications and control medications. In a person that has an acute wheezing attack and needs immediate relief, we use short-term relief medications like short-acting beta agonists or steroids. Steroids may be in the form of oral steroids or intravenous corticosteroids or inhaled steroids of a higher dose. Lately, short-acting anticholinergics have been also suggested. Control medications are inhaled corticosteroids are the most common ones that we use. Over the past 3-4 years, biologic medications have come into play and are very effective, and I'll elaborate a little bit later. Leukotriene modifiers like Singulair, inhaled long-acting bronchodilators, immunotherapy, and mast cell stabilizers. The various biologic agents in the treatment of asthma, these are the various common ones. Basically, they again attack at the cellular level so as to prevent disintegration of the cells and release of the chemicals, and that's how they work. It's mainly seen in patients with elevated IgE levels and eosinophil level. Immunotherapy treatment, again injecting allergens under the skin, or as Dr. Balwani suggested, drops, can reduce asthma, and the use of medication improve the sensitivity of the lungs, but with the risk of severe reactions sometimes. In case of severe asthma attack, the patient may be treated with medications such as those listed above, given with a nebulizer or intravenously. They may also receive oxygen therapy or breathing assistance depending upon the severity. This may include ventilator support or through a mask with forced air. I would like to mention a certain kind of procedure which is a non-pharmacotherapeutic treatment for asthma. If you remember the diagram I'd shown you, the cross-sectional diameter shows an increased muscle mass. In this case where the patient has severe asthma not responding or difficult to control, through a bronchoscope, which is a rubber tube with a light at its end, which we introduce into the breathing tubes. We then introduce another wire which transmits heat energy, and this decreases the muscle mass and destroys the muscle mass within the mid-size breathing tubes. And this limits the spasm that can occur to constrict the breathing tubes and thereby decreasing the asthma. This is especially useful in patients that are using steroids, oral steroids long-term, and causing increased appetite and obesity. So in those patients, this is a significant help. So here is the hypertrophic muscle mass. And this is the muscle mass we aim to reduce by applying heat energy and increase the lumen size so that there isn't increased shortness of breath. All asthmatics should have an asthma action plan. And in this, they need to identify the allergens and irritants and avoid them. They need to be educated regarding how to handle an asthma attack. They need to know which medications to take in case of an increasing symptomatic asthma, when to call your physician or go to the emergency room. So that's the conclusion of my talk. I'm happy to take any questions. Hello?
Hi. Okay. So we do have a couple of questions in the chat box, and I would encourage everybody to put their questions in the chat. Let's see here. So one of the questions is how can you know when you've gone from allergic rhinitis to asthma?
So the symptoms, there are some commonality in the symptoms. Cough is the most common symptom that affects both nasal congestion and asthma. But when you are expectorating sputum or you have wheezing, chest tightness and shortness of breath, the latter three symptoms would probably differentiate asthma from allergic rhinitis.
I would agree. I mean, I think it's a good question.
Mm-hmm.
You know, with allergies, really, for me at least, being an ear, nose, and throat physician, is more of a quality of life issue. Asthma is truly a health issue, although, as I mentioned, with allergies, it can lead to asthma, sinus problems, and other things. But allergies are mainly more of an upper airway, nasal issue. And so if that's all you have, you can try over-the-counter stuff or come in for allergy testing. But once it starts becoming a cough or any breathing or wheezing issue, I think that really needs to be addressed by, you know, someone like Dr. Patel or a pulmonary physician.
Okay. So I guess that's the other question is, when should somebody seek a specialist for the treatment of either allergic rhinitis or asthma?
From my standpoint, it depends on your quality of life. I mean, a lot of the stuff I deal with, ear, nose, and throat, is more of a quality of life issue. And if your nasal problems, congestion, breathing issues are affecting your quality of life, or it's causing a lot of sinus problems, then I think it's worthwhile to have them addressed by an ear, nose, or throat physician. I will say that, you know, we do allergies in ear, nose, and throat more from a sinus standpoint. There's also allergist immunologists who also treat allergies. So depending on the severity of your reactions, you can see either. But if someone has severe symptoms with either asthma or other issues, I'll either, certainly if it's asthma, I send them to someone like Dr. Patel, but I also recommend at times seeing an allergist immunologist, because my bend is more dealing with the nasal issues that lead to sinus problems and just congestion. So mine is more of a specialized, just upper airway thing.
So as far as asthma and referring to a specialist, I think mild asthma is usually can be taken care of by primary care. It is the moderate to severe asthma that might require a specialist help. And those that have had to take a steroid burst more than 2 times a year for 2 or more years, or have a breathing study that shows significant reduction in their airflow or hyperinflation, then that's the time they should go to the specialist.
Okay, what are the most recent advances in the treatment of either rhinitis or asthma? Has there been something out there that will just take care of the problem? Can it be prevented altogether?
So it depends on the cause of that symptom. So if the person has shortness of breath and has rhinitis and has elevated eosinophils, then one of these biologic agents that I showed, the dupilumab or Dupixent, can address both allergic rhinitis and asthma. So the biologic agents can do that. The downside of that is that they are injectables. They are not sublingual or oral. So it is something that needs to be in a parenteral form. But the good news is that now they have come out with injectable forms that can be taught to the patient or their family and be done at home after the first 1 or 2 doses. When there is no evidence of any reaction, then they can do that at home.
What are the side effects of these new treatments?
So the side effects are one of definitely an allergic reaction from anaphylaxis, which is where the breathing tubes close up, to a slight decrease in immunity. So those that have chronic infections, tuberculosis and things like that, not for them. So mainly we have to be careful about chronic infections in these folks.
So can asthma be prevented?
Asthma can be controlled. It may have a genetic component to it. I'm not sure it can be completely cured, but it can be controlled for sure.
How about rhinitis?
I'm sorry, what was the question again?
Can it be prevented?
I don't think it can be prevented. I mean, you can take measures to avoid symptoms as much as possible. I mean, I think telling people, like I was saying, not to go outdoors, part of life is enjoying the outdoors. So I don't think you can truly prevent it, but you can take measures to decrease your exposures. There are certain things that you can do. Dust mites live in bedding and carpets, and you can try and use anti-allergy pillow covers and bed sheets. You can wash your sheets in hot water twice a week. You can get a vacuum cleaner that takes a lot of the particulate matter out of your carpets. So there's things that you can do to reduce exposures, but it's really hard to completely prevent it.
So one of the comments was that yoga and pranayam helped a lot with allergic rhinitis for that particular individual. Are you familiar with any research in this area?
I'm not, but I'm trained in a certain way in allopathic medicine, and there's lots of other methods, whether it's acupuncture or Eastern medicine, or that actually do help people. So I never discourage people from trying things as long as it's not cost prohibitive and as long as they're not putting themselves at risk depending on the disease process. So I'm not aware of it, but I think if it helped, then that's great.
So in asthma, because of it is a shortness of breath thing, that in itself intrinsically sometimes brings about anxiety, and then that becomes focus sometimes where it, even if the patient doesn't have asthma, the anxiety takes over and makes them short of breath. So whether the pranayama or the yoga allows them to overcome that part of the symptom complex, then it might help. I'm sure there are anecdotal evidence out there where they have said that, if they can control the rate of breathing, then they're able to decrease their spasm, because as I mentioned earlier in the talk, when you increase your rate of breathing, you're not able to warm and moisten the air. And when cold, dry air hits the mucus level of the bronchi, that flux in temperature between the body temperature and the cold air, that triggers the spasm of the smooth muscles around the breathing tube, which in turn causes asthma. So if you're able to control that rate of breathing, the flow rate, and trying to breathe through the nose rather than the mouth, in some cases it might help.
Anybody else with questions? You can either type them in the chat box, or you can unmute yourself and ask the question directly. Okay, I'm seeing no more questions. I wanted to take this opportunity to thank Dr. Balwani and Dr. Rajesh Patel for excellent presentations on these topics. Thank you for sharing your valuable time with us this afternoon. We really appreciate it. And thank you everyone for joining us despite it being Mother's Day. Have a wonderful rest of the day. And
Thank you.
we'll see you next month. Take care. Bye-bye, everyone.
Bye-bye.